اوكي معايا؟
الصبح.
ايوه، ازيك يا باشا؟
ازيك يا سعاده الرئيس؟ ازي سعادتك؟
ازيك جميع؟ طبعا في البدايه عشان ما يتحسبش وقت من البرزنتيشن لسه ما ابتديناش، بحب ابعت شكري لاخي العزيز دكتور صلاح نجا ودكتور محمد سعيد وكل حبايبي في جامعه اسكندريه، وانا سعيد بهذا اللقاء وكان نفسي ابقى معاكم، انما هي بس الظروف اللي خلتني ابقى فيرتشوال اند نوت فيزيكال.
هو طبعا في الاول لو سمحت لي يا دكتور محمد، هو شرف عظيم جدا ان الواحد يتلمذ على ايديك. الواحد بيفتخر بهذا الكلام لانه فعلا حضرتك مثال الخلق الرفيع، الاتيتيود الرائع، الريسيرشر اللي ما حصلش، ويكفي ان حضرتك تمتلك الهايست رانك من الاتش اندكس اللي بيعكس الريسيرش على مستوى كل الارب وورلد كنفرولوجيست، فده توب. واحنا النهارده هنبقى مستمتعين جدا. كنا نفسنا تبقى حضرتك معانا لكن حضرتك قلت لي على السبب، فهنستمتع اكيد بالمحاضره. اعتقد انها تبقى ثريه جدا لان حضرتك من الليدرز في الهيباتيتس سي جلوميرولوباثي، لما كان الانسايت في سنه 2000 ان اتعمل كاركترايزيشن في التيشو، وكان اول بحث يتعمل في الاتش سي في كاركترايزيشن وورلد وايد. فاكيد هنسمع من حضرتك كلام ثري جدا في الفيرال نيفروباثي ابديت. اتفضل.
هو حقيقة يعني title of this presentation is very interesting for many factors. Number one, we know we lived together the era of HCV and kidney. And currently we are living the era of COVID and kidney. And we don't know what is the future coming with. Possibly extension of COVID or possibly new viruses are coming to appear as part of possibly biological war. Now I'm going to talk about the story of viral nephropathy. We know glomerular injury can occur in a number of viral infections. Primarily, as we know, hepatitis C virus, B virus, BK virus, HIV, and recently COVID virus. But we know that the advent of better antiviral therapeutic agent has modified associated glomerulopathies and improved progresses for patients with virus-associated glomerulonephritis. I will start by that is able to cause chronic hepatitis, cirrhosis, and hepatoma. Up to 90% of infected patients have a chronic infection with HCV virus inducing polyclonal antibody response and the vulnerability to immune complex. So the immune complex is the backbone of pathogenesis of HCV-related glomerulopathy. And we know RNA of HCV has been detected intracellular in the kidney. Also, toll-like receptor 3 may be a pathogenic role in the development of glomerulonephritis. Another way is the association with immune complex production. The HCV-E envelope 2 protein can induce an IgM rheumatoid factor, which is the cause of the more aggressive form of HCV. So, okay. As regards the clinical manifestation and the pathology of HCV, most patients with HCV-associated renal disease are asymptomatic, as we know. But when symptoms occur, we can get nephrotic syndrome in 20%, we can non-nephrotic proteinuria, nephritic syndrome, microscopic hematuria, but we know hypertension is dominant in the manifestation of this disease. HCV may be associated with MPGN, this is the commonest, membranous nephropathy, mixed cryoglobulinemia syndrome, and one of our publications is talking about the comprehensive study of association between HCV and glomerulopathy, and we have described the clinical and pathologic criteria of this disease among Egyptians. But other reported associated glomerular nodosa, fibrillary glomerulonephritis, immunotactoid. Of course, these are rare lesions, but are counted with HCV related glomerulopathy, mesangial proliferative, also focal segmental, even collapsing type. But of course, this in special ethnicity, especially the African American. Of these glomerular lesions. I will go directly to the treatment of HCV. I'm not going to talk about pathology since Dr. Fatma Hussein will go deep into this point. If I talk about treatment, in general, patients with progressive HCV glomerulonephritis should undergo antiviral treatment, provided, of course, that they don't have decompensated cirrhosis or short life expectancy due to other comorbidity. In addition to antiviral therapy, patients with severe and progressive will need immunosuppressive drug as well. So antiviral for all, steroid and immunosuppressive for special category. And this is another publication which we published in 2002 about eradication of the virus HCV on its related glomerulopathy, and it was very interesting discussion, publication. If we come to, we know there are a lot of regimens to treat HCV in general patients. If we go to the regiment selection, it is the same policy like non-renal patient. It depends on the extent of renal disease, extent of liver disease, genotype of the virus, and associated comorbidity. You apply the same rule with our patient. But in general, these are the combinations of antiviral drugs, which we consider pan-genomic. So it can be used with any type of HCV genome. But now we have renal patient. If we come to the renal patient, these combinations are used freely in our renal patient, even if they have renal dysfunction, and in our patient genotype 4. Another combination, this is another combination of anti-HCV, which is used in type 4 HCV and can be used in our patient with renal impairment, even balanced patient, but of course, they should have compensated liver disease as well. A patient with severe renal injury, such as those with polyarteritis nodosa or mixed cryoglobulinemia with vasculitis, we have to give immunosuppressive drug and antiviral. But the wisdom is to give antiviral first, immunosuppressive drugs first. Then after 1 or 4 months, you start giving the antiviral. This what we do, and this is an agreement of many of the scientific organizations. Why? What is the rationale behind giving immunosuppression then antiviral drugs? The wisdom is that because you need rapid response of this florid, aggressive disease. Actually, immunosuppressive have rapid effect, while antiviral have a gradual effect. So we start by the immunosuppressive drugs. Also, there is another point, which each drug have its side effect, immunosuppressive and antiviral. If you start by 2 agents, side effects will be more. So you use immunosuppressive to take down the inflammation, then you start eradicating the virus. Another reason, if you use Rituximab, you are going to eradicate B cell, which contain a lot of virus. So you decrease the viral load before giving antiviral drug, which improve the action of antiviral drug. So this first immunosuppressive, second antiviral drug. Another point of interest, those who are going to take sofovir containing regimen, take care, this can cause kidney injury, and you have to follow serum creatinine every 2 weeks, especially the patient is predisposed, such as having little bit high creatinine, or he is diabetic. Take care, creatinine can go up, so twice, every other week, look for his creatinine. If there is a problem, stop this combination immediately. Regarding corticosteroid and rituximab, of course, for cryoglobulinemia, you have to use both drugs together. Don't give steroid only, but start steroid plus rituximab and not cyclophosphamide. Rituximab, how much given? There are 3 regimens. The first one is the regimen used with rheumatoid arthritis, in which we give 1 gram. Then after 2 weeks, we give another 1 gram. This is all. Another regimen in which we give the dose of 375 milligram per square meter surface area and give it weekly, 4 doses, 1 week apart. There is a third regimen in which we give the 4th dose, then another 2 consolidating doses with 1 month apart. This is regarding the rituximab. Alternatives to rituximab, of course, rituximab and steroid is the best, but you can use cyclophosphamide, but there is a warning. This should not be #1 treatment. If you have rituximab, it is rituximab. Especially if you have combined C and B, can cause viral fillers. But still, if you have a life-threatening condition, such as severe pneumonia, pneumonitis, for example, cerebritis, or something like this, you can use cyclophosphamide if you don't have rituximab. Cyclophosphamide to be given oral or intravenous. Most organizations believe in giving it intravenous since you can achieve the target with a less cumulative dose. There is a limited role of plasmapheresis in this condition and makes it in cryoglobulinemia, but we can use it in when we have a patient with hyperviscosity. If we have a life-threatening condition such as pneumonitis, rapidly progressive crescentic glomerulonephritis, or you have severe cutaneous vasculitis with ulcers. Now I will leave virus C and I go to virus B. We know virus B is a DNA virus. You have the surface antigen, the core antigen, and the envelope antigen. Actually, so you have 3 antigens. It causes immune complex disease, and actually this immune complex has been documented or detected in the kidney tissue as well as in the circulation. Even when the immune complex in circulation go down, there is a remission of membranous nephropathy. It has been with hepatitis B patient. Immune complex depend on the antigen, dominant antigen. Since, for example, E antigen is a small and a cationic, so it go into subepithelial, causing membranous nephropathy, while core antigen and surface antigen are larger in size, so they are trapped in the subendothelial or mesangial. So it can give you mesangial capillary or mesangial lesion, especially. Also, we have the in situ theory, in which the core antigen is trapped, then immune complexes are formed in situ. The virus can have a cytoplasmic mechanism, so can cause direct damage to the kidney. If we go to the clinical manifestation, we have the acute infection, acute hepatitis B. Besides the known general clinical criteria of acute B, we have hematuria, we have non-nephrotic proteinuria, but no renal biopsy data in this acute lesion. But we know usually it carries a good prognosis and the disease resolve and consequently kidney lesion resolve. The problem is not in the acute B, but in the chronic B, in which we know that 3 to 5% of patients develop chronic kidney disease. In addition, we know that these B patients, 10 to 30% of them have in addition a C or HIV, which known to cause nephropathy, so increasing the burden on the kidney as well. The commonest lesion with hepatitis B is membranous nephropathy. This is the commonest. In the children, it takes a good quiescent course. So usually they resolve spontaneously. So a child with B, even coming with membranous, don't rush and give treatment. Wait for spontaneous resolution. But in adult, the disease is more aggressive. So more aggressive, it becomes chronic, and your patient, a good percentage of patients will go into 30% will go into chronic kidney disease, and up to 10% will go to end stage. Also, hypochromia can be present in this type. Membranous proliferatives can occur in B, as we know, as the virus can be, copies could be trapped subendothelial and mesangial. Also, mixed cryoglobulinemia can occur in this lesion, especially if we have associated C. Besides membranous and vaginal capillary, are other lesions with B? Yes. IgA nephropathy has been reported, and also even authors reported that on treatment of B virus, the IgA nephropathy disappeared. But this is disputed, since others reported failure to induce remission by anti-B treatment, adverse B treatment. And others say it could be coincidence, since we know Southeast Asia, in which B virus is common, also A virus is common. So it could be coincidental finding. But it has been reported. Other case report of post-infectious glomerulonephritis has been reported. Amyloidosis has been reported with hepatitis B as if it is a chronic infection. Even case report of collapsing focal segmental glomerulonephritis has been reported with hepatitis B infection. If we come to treatment, we know it is two things: interferon and nucleoside analog. Combination is good. And from this analog, lamivudine, which we have it, and entecavir, these are the best. And either single drug or combination, of course, combination gives better result. Dose adjustment is required with a reduced kidney injury. Interferon can induce remission, but don't use in decompensated, never decompensated patients, since it will be very serious. Usually we use 5 mega unit daily or 10 mega unit 3 times weekly. And these are the lamivudine. Its price is good, so it encourages us to use initially. So usually it is used as initial therapy in 1 tablet, 100 milligram. It induces remission in 75 to 80% resolution of membranous nephropathy with a reduction of hepatitis B DNA. But this drug, unfortunately, has a 20% annual rate of resistance. So expect that your patient will need entecavir after a period of time. Of course, you need a good dose reduction with renal impairment. You give full dose down to estimated GFR of 50 milliliter per minute. But below this, you will go down to half tablet a day for 1/8. And in balance patient, you will use 10 tablets. So you decrease, you take fraction of the tablet. Entecavir is better than lamivudine. It can be used in naive patients, in patients refractory to lamivudine. Entecavir is less resistant and give good result. And the dose is 0.5 milligram daily. And also this estimated for 50. But if you go down with the function, you go down with the dose. But here, you don't fractionate the tablet, but you increase the period between tablet and other. So 1 tablet every other day, every 3 days, and in this patient, weekly. You give 1 tablet weekly. Of course, treatment should be maintained for 12 months after seroconversion and demonstration of undetectable hepatitis B DNA. Of course, except in patients with cirrhosis, in whom you have to give treatment forever. Tenofovir, we don't like it. So simply, it is nephrotoxic. It can decrease the bone density as well. What about corticosteroids? There was a story which say don't give corticosteroid with antiviral in B patients, since it will flare the infection. But actually, there is a meta-analysis of 12 clinical trials. And they found that combined antiviral and corticosteroid therapy can improve the proteinuria. So you can use it if you have severe kidney lesion. The story of COVID. All people talk about COVID, so I'm going to the very practical point in this issue. As coronavirus, we know, has been emerging, we started to be involved in kidney, sort of kidney and the COVID. If we talk about human kidney as a target of COVID infection, of course, there is a talk about many the COVID directly infect kidney via ACE, which is widely expressed in proximal convoluted tubular and podocyte. And this, Dr. Gamal Saadi have went into a great detail regarding this point. But we have to know that this receptor is dominant in podocyte and in proximal convoluted tubule. And they found that the density of this receptor for COVID are equal to those present in the lung and intestine. So the kidney is as important as the lung, I mean. They proposed the mechanism of acute kidney injury, since this is the dominant clinical presentation, range from direct viral infection, a mechanism which is disputable, of course, to an effect on renin-angiotensin system, aldosterone system, and hemodynamic instability, coagulopathy, and cytokine storm, organ damage, such as rhabdomyolysis can affect the kidney in COVID patient. Acute kidney injury is one of the important complications of COVID, occurring in 0.5 to 7 an overall patient affected by COVID. But those going to isolate acute kidney injury can go up to 23% of patients. However, whether acute kidney injury COVID is caused by coronavirus-induced cytopathic effect or cytokine storm and other mechanisms, there is dispute. But most of researchers now talking that the virus don't have effect on the kidney. This is an interesting paper coming from China, studying the kidney lesion in human. Actually, they examined 85 patients with laboratory confirmed COVID and examined all the parameters related to the kidney laboratory and histopathologic finding. And actually, the dominant lesion they observed is acute kidney injury, which they found it to be present nearly in 30%. 23 out of 85 patients developed an acute kidney injury. When acute kidney injury usually occurs in this patient, usually in day one admission to the hospital, and also another peak of acute kidney injury occurring at day 8. And also they observed that most of acute kidney injury cases occurred when they started ventilator. So with ventilator, expect acute kidney injury. This table could be somewhat busy, but they examined all the variables to look what factor related to acute kidney injury was found significant with age, male preponderance, also diabetes, hypertension, cardiovascular disease, respiratory disease, obesity, chronic liver disease. They found that all these can affect. Here, as Dr. Gamal Saadi said, the last one, ASNR, they found no relation with ASNR and occurrence of acute kidney injury. Interesting. Also, the inflammatory milieu, another mechanism, inflammatory milieu surrounding COVID also may trigger or exacerbate immune-mediated disease in predisposed patient. Example, including crescentic transformation of the long-standing class 2 lupus, or T-cell mediated rejection in a graft which was stable. We know interferon and granulocyte collagen stimulating factor play an important role in triggering acute rejection or exacerbate immune complex mediated glomerulitis. This is a general fact. And both cytokines are known to be elevated in patients with COVID. So it is not strange to say COVID will excite rejection. COVID will aggravate lupus nephritis. This is the mechanism. If we come again to the acute tubular injury, also has been identified as a predominant finding in autopsy series. Etiology is likely to be multifactorial with complex interplay of sepsis, hypoxia, hemodynamic instability, nephrotoxin exposure. You give drugs. And last month, I saw a doctor with acute COVID coming to me with acute kidney injury, which was found to be drug-related, not COVID. And he recovered completely from his acute kidney injury. And also, multi-organ complication can cause kidney injury, such as cardiomyopathy, cardiac failure, or rhabdomyolysis can cause acute kidney injury. If we come to the management of acute kidney injury in hospitalized patients, of course, number optimization volume status is very important. Exclude pre-renal factor and treat it. Also avoid hypervolemia. This is very important. This is a respiratory problem. If we come to dialysis, of course, it is the same story. Like patient with acute kidney injury and hemodynamically or respiratory unstable, we use renal replacement therapy, and also SLID can be used in this patient who are hemodynamically unstable. If we come to chronic kidney disease and hypertension, of course, chronic kidney disease patients are liable to get COVID more. Dr. Saadi has got this point, ACE and ARBs and hypertension to continue or not, and explained it very clearly. If we come to kidney solid organ transplantation, solid organ transplant recipient may be at increased risk of COVID because they are immunosuppressed and have frequent contact with healthcare system. They go much to the hospital, a source of infection. There is also a theoretical risk of transmission of virus through donated organ. This is the reason for which they stopped activity in most transplant centers. But like other immunosuppressive person, solid organ transplant recipient may shed greater amount of virus. This is very important for longer duration than otherwise healthy person. Why? What is the meaning of this? Thus, they may become more likely to spread infections than others. And also, if they recover, they need longer time to stop shedding virus. Further data is needed, of course, to confirm this notion. To optimize, to minimize the risk of infection and conserve hospital resources, they started to decrease activity in hospital doing kidney transplantation. But life-saving transplantation is a must, and we should practice it, irrespective of COVID. Now, clinical feature of COVID, the same, but of course, fever will be less since they are immunosuppressed. Lymphopenia will be more aggressive in transplant patients. This immunosuppressed patient are higher risk to severe disease or not, this is interesting point. Since as we know, immunosuppression will make the patient get infection more. But we know the killer number one for this patient is the cytokine storm for which we give immune suppression. So this is something need further study in this situation. Effective immune suppression.
دكتور محمد.
ايوه.
ماشي. عشان بس التايم هنا صعب جدا، ف دقيقتين وحضرتك تخلص ولا لسه قدامك قد ايه؟
والله هي متروكه للكرم بتاعكم. احنا هكمل بس قبلها بخمس ثواني قول لي خلاص. لان انا دلوقتي بخلص الكوفيد قدامي بي كي، ممكن اي ستوب بي كي but I finish COVID after 1 or 2 slides.
اوكي يا باشا.
Okay. Now to the suppression in solid organ transplant population on COVID disease. There, as I said, there is interplay, immune suppression, good phase and bad phase, which need further study. Management, of course, what to do about immune suppression. Adjust immune suppression. It should be individualized according to the doctor experience. Also, of course, severity of the COVID. specific regimen used, type of organ transplanted, time of post-transplantation, all these work in manipulation. But of course, usually we attack the mycophenolate or the anti-proliferative drug. We put in our mind, if the disease is very calm, we don't manipulate our immune suppressive drug. But once start to show serious phase, this COVID, I started to decrease dose of mycophenolate, reducing 50%, removing it alone if we have cough, if we have pulmonary infiltrate, for example. Immunosuppressive or cancer also is interesting. As we know, cytokine storm caused by interleukin 6 it can kill the patient, and calcineurin inhibit this interleukin 6. So it needs to sit. If it goes to bad setting, I start also decreasing calcineurin. But the COVID is severe, so usually even we increase the dose of corticosteroid. Experimental data suggests that certain immunosuppressive agents, such as mTOR inhibitor, may have some biological activity against SARS. What is the clinical application? We need a randomized trial of this. Drug interaction, we know ST segment, of course, calcineurin cause QT interval. So take care of azithromycin. Of course, hydroxychloroquine is not used now for COVID, but azithromycin is used routinely. In addition, of course, the protease inhibitor can affect the metabolism of calcineurin and can cause severe elevation of blood level and can cause acute kidney injury. Take care of this company. PK, it was very interesting, but for the sake of time, I will leave especially the histopathology, which will be given more detail by Dr. Fatma. I would like to stop here to make the matter easy for the panel. And thank you.
Thank you very much, Professor Sobh, for this presentation that reflects the deep experience in the field of viral associated kidney disorders. And we enjoyed your talk about COVID-19 because it's one of the hot viruses. But because of the time restriction, and we are waiting, we have still many speakers before the Professor Richard Glassok, and the organizers here are very anxious about the Richard Glassok time, because we are exceeding our time. We will proceed to the next speaker and reserve the question to you to the next time, inshallah. Thank you very much, Professor Sobh.
Yes, thank you. Thank you.